Hi everybody, my name is Saeid Hady, and I am a professor in obstetrics and gynecology at Mansoura University in Egypt. Today I am going to present maternal mortality, the global, regional and Egyptian view. The objectives of this presentation are: number one, to know the definitions, and then the global view, the regional view in the region of Eastern Mediterranean, the national view, the Egyptian view, the main causes, the preventive strategies, and the sustainable development goals, as maternal mortality is one of the Sustainable Development Goals for the United Nations. Definitions: maternal mortality is defined as maternal death due to causes related to or aggravated by pregnancy, labor, and puerperium. The causes that are related to are called direct causes, and the causes that are aggravated by are called the indirect causes. The maternal mortality ratio or rate, known as the MMR, is the number of maternal deaths per 100,000 live births. Why we relate it to the number of live births? It should indeed be the number of all pregnancies, but all pregnancies that end in miscarriage or even that end in stillbirth are not recognized, are not registered, and so we just take the live birth, which is registerable by law. From this perspective, it is often an underestimate because stillbirth and miscarriages are not registered, although they can end in maternal mortality. The direct causes are the causes that are induced by pregnancy and childbirth, and the major causes are bleeding, hypertensive disorders, and thromboembolism. The indirect causes are pre-existing diseases that are aggravated by pregnancy and childbirth, such as cardiac diseases, diabetes mellitus, hematological disorders, and so on. The associated causes are neither related to or aggravated by pregnancy and childbirth, such as the accidents, the suicide, and the homicide. So we have the direct causes, the indirect causes, and the associated causes. These are the definitions. Regarding the global view, every day more than 800 women die from preventable causes related to pregnancy and childbirth, which we call it unnecessary maternal death. The maternal mortality ratio in the developing countries in the year 2015 was 239 versus 12 per 100,000 live births in the developed nations. That's to say, the ratio in the developing nations compared to the developed nations is around 20 folds, and that reflects the status of socioeconomic and maturation of the health system in both developed and underdeveloped world. And this comes the role of the international organizations, mainly the United Nations and the Sustainable Development Goals. Maternal mortality is higher in women living in the rural areas and among poorer communities. So even in the same country, the poorer ones are more liable to die as a result of pregnancy and childbirth. Also, the young adolescents, the teenagers, face a higher risk of complications and death as a result of pregnancy and childbirth than the other women. So, rural areas, poorer women, young adolescents or teenagers, and the elderly women are more liable to die as a result of pregnancy and childbirth. However, there have been efforts done to reduce maternal mortality in the global view, and between the years 1990 and 2015, maternal mortality worldwide developed by nearly 44%. So there is good effort is done, but we are hoping for more effort to reduce maternal mortality. Between 2016 and 2030, we have target to reduce the global maternal mortality ratio to less than 70 per 100,000. So right now it's above 100, but now we are aiming to reduce it by 50% to make it 70. It's a very ambitious target, but we're going to see. Again, global, regional, and national levels and trends of maternal mortality between the year 1990 and 2015 is published in a very good article in The Lancet, 2016, volume 387, pages 462 to 464, to those who are interested to read about that topic from The Lancet. That slide shows the magnitude of the problem by different parts of the world, and you can see from that slide that almost 99% of maternal mortality occur in the developing world, mostly sub-Saharan Africa. Comes next is the Southeast Asia and then the Latin America. But indeed, this graphical representation of whole nations of the world shows clearly that maternal mortality is a problem in the developing nations. As we said, over 99% occur in developing nations, particularly Africa, and there have been a maternal mortality program developed by the United Nations Prevention Program, the FIGO, Federation Internationale d'Obstetrics and Gynecology, Society, International Society for Obstetrics and Gynecology, have done great work to reduce maternal mortality in Africa, and this has produced good results. Again, that's a maternal mortality distribution in the world, and you can see that 99% occur in developing nations. Around 70% of all maternal deaths occur due to bleeding infection and eclampsia. That's to say, the direct causes are responsible for 70%. Only 1% of all maternal deaths occur in the developed and high-income nations, and the rural areas represent 34% occur in developing nations which have no access to antenatal care, but the urban, the situation is much better. Still in the global view, more than half of all maternal deaths occur in sub-Saharan Africa. So over 99% occur in developing nations, and over half of all, over 50% of all maternal deaths occur in sub-Saharan Africa. So the situation in African countries is desperate. And more than half of maternal deaths occur in the fragile and humanitarian settings. So in countries which have civil wars and conflicts, maternal mortality is much higher. Almost 1/3 occur in Southeast Asia. So over half in Africa, over 1/3 in Southeast Asia, I mean in the region of India, Pakistan, Bangladesh. Coming to the regional view, as we said, in sub-Saharan Africa, a number of countries have significantly reduced their levels of maternal mortality since 1990. In other regions, including Asia and North Africa, even greater reduction. So there had been work, as we said, but it is still not sufficient. There is large disparities, not only between countries, but also within the same country, between women with high and low socioeconomic standards and women living in rural and urban areas. That's to say, socioeconomic development is the best way to reduce maternal mortality. That is the graphical representation of the maternal mortality ratio in the region, as we said, that focus on the Arab region. If you take United Arab Emirates, the maternal mortality ratio is 3 per 100,000. Then Kuwait 5, Qatar 10, Oman 14. That's the Gulf area. United Arab Emirates, Kuwait, Qatar, Oman, and even Saudi Arabia is around 20 per 100,000. So these are the high income countries in the Arab world. Taking the middle countries, the Jordan, Syria, Tunisia, and Egypt, it comes between the 20 up to Lebanon, 100 per 100,000. Look at the other countries, Morocco, Iraq, and Yemen. Yemen is around 350 per 100,000. Iraq is around 300 per 100,000, and Morocco is 230. So the rich nations have low rates, the middle income countries have a middle ratios, and the low income countries and countries with civil wars have the highest. And this is graphical representation of the link between maternal mortality and socioeconomic development. In Egypt, there has been a success story in the maternal mortality reductions from the year 1990 when the first census starts. Now we speak about around 33 per 100,000 live birth maternal mortality in the year 2015, but we started from 183 in the year 1993, and then we come down to 86, and then to 60s, and in the last census we are 33 per 100,000, which is not bad, but we can still do better. That graph shows the maternal mortality in Egypt between the years 1990 till 2015, and you can see the reference is the World Health Organization, the UNICEF, the UNFPA, the World Bank, and that is the formal statistics. In the year 1990, the number of per 100,000 live birth of maternal death was 106. 1993 per 100,000 live births was 83. 2000 63, 205 52, 2010 40, and 2015 33. So there have been a steady decline. But look at the far right end. Look at the live birth per thousands. In the year 1990, there was 1871,000, and the number of live birth in the year 2015 was 2488. That's to say, also the number of live birth has drastically increased in Egypt. So the number of maternal mortality has come down, but the number of live birth has come up, and this reflects the population growth in Egypt. The main causes of maternal mortality, as we said, we classify it into direct, indirect, and the accidental one doesn't count. But the major complications that account for nearly 70 to 75% of all maternal deaths are the direct causes on the whole global standard. Severe bleeding, mostly bleeding after childbirth, high blood pressure during pregnancy, preeclampsia and eclampsia, thromboembolism and other complications. These are the main direct causes. Again, infections usually caused by miscarriage and unsafe abortion. These are the global. But remember that over 99% of maternal mortality occur in the developing poor nations. So the sequence of these causes varies between nations. In the developing nation, it is bleeding, hypertension, and thromboembolism. But in the well-developed nation, it is the opposite. It's thromboembolism, followed by hypertension, and lastly, bleeding. Again, the direct causes represent 75% in the developing nations. But take care, because the indirect causes of maternal mortality that are aggravated by pregnancy and childbirth are more than 50% in the well-developed nations. So the global view, although the hemorrhage and hypertension and sepsis are the more common, but these are the view in view of the fact that 99% occur in the developing nations. But in the developed nations, mostly the indirect causes, and even for the direct causes, it is thromboembolism rather than hemorrhage and bleeding. In Egypt, the direct causes represent over 75% of all causes of maternal mortality, so the same picture of the developing nations. Mainly severe bleeding, mostly postpartum hemorrhage, preeclampsia and eclampsia, and now death during cesarean section, mostly due to morbidly aberrant placenta or placenta accreta, which is now seems to be the most common cause of maternal death in Egypt because of the very high cesarean section rate, and this will come to at a definite later. Postpartum hemorrhage is still the most common cause, but as I said, now the postpartum hemorrhage occurs mostly after delivery of the placenta in cases of placenta accreta and placenta previa. The cause of postpartum hemorrhage are 4 T's. Tune is atonic postpartum hemorrhage, as in twins hydramnios. Trauma and lacerations and ruptured uterus. Tissue, retained products of conception, placental cotyledons, membranes, and from pain, fibrogen deficiency, as in DIC. So the causes of postpartum hemorrhage are atonic, traumatic, retained products of conception, and DIC. Can we prevent maternal mortality? There are strategies include the woman herself, the family, the community, and the global view on how to reduce maternal mortality. But we can summarize that we need better obstetric care, we need availability of the health care services, and we need socioeconomic development. These are in broad terms. Better obstetric care, we need well-equipped and easily accessible maternity services. We need well-trained staff, obstetricians, anesthetists, midwives, neonatologists, assisting staff, blood transfusion facilities, so all deliveries must be conducted in well-equipped hospitals, readily available transportation. Even it does make a difference if a woman doesn't find a facility to transfer her to the hospital, then she could die, especially of bleeding. And we need intensive care facilities in the high risk. So if you have a very well-developed health system that will cover all these areas, definitely the maternal mortality is going to be reduced. In Egypt, we forbid deliveries at private clinics. It's now all deliveries should be conducted in well-established hospitals, and definitely this contributed to the reduction in maternal mortality. Availability of healthcare services. We need antenatal care. As we said, only 1 in 3 women in Egypt now receive proper antenatal care. Care during delivery is a bit better. Postpartum care and social support. Socioeconomic development, as I said, is the most important for reduction of maternal mortality, not only in Egypt, but on the international standard. Addressing inequalities, as we said, in the rural areas, women die more than in the urban areas. In the poor community, they die much more than in the rich community. Ensuring universal health coverage for comprehensive reproductive, maternal, and neonatal health. So it's only not only maternal, but that is a continuum from the reproductive health, the maternal mortality reduction initiatives, and even the neonatal care. In Egypt, as we said, there have been a success story and a significant reduction in maternal mortality from the year 2000 through 2018, and most recently even is coming down. And the main role was socioeconomic development and investment in the healthcare system, and also forbidding all maternal deliveries or all childbirth except in well-equipped hospitals. Coming to the last Sustainable Development Goals, we need to address all causes of maternal mortality and strengthen the healthcare delivery systems. We need to ensure accountability in order to improve quality of care and equity. Accountability, those who are responsible should be to take the responsibility to enhance the health care, to push money and the investment in the healthcare system, and to have equity. So the rural area should have equal opportunities for proper and safe childbirth as in the rural as in the urban, and poor as exactly as the rich. So from that lecture, we have said that yes, the maternal mortality in the global view is coming down, but we still do much more effort to reduce it. We said that it's 20-fold in the socioeconomic deprived countries than in the developed nations. We said that Africa, especially sub-Saharan Africa, represents 50% of maternal mortality and another 30% in the Southeast Asia. We said that proper health care, socioeconomic development, and facilities for blood transfusion, so I mean blood banking, will equip the hospitals, train the staff, can make the difference. I wish you all the best, and we have shed light on the views both globally, regionally, and nationally. Again, thank you very much. I'm Saeid Abdul Hady and wishing you all the best. Bye-bye.